So I learned this a couple years ago, and these little passports work really good in your practice too. So we do an event called Bubbles and Botox in December every year that we have all of these like little stations. So we'll have a frame style sunglass station, we'll have a skincare station, we'll have IPL, RF, neurotoxin. No, I'm not doing neurotoxin when I'm injecting people and alcohol. It's a bad combination. But we do just a consult of what we could do with neurotoxin. But all of those little stations, they get a little passport. And so the patient goes through each station, they get a little stamp, and then we have all of these drawings and things to do as they move through the practice. And that has been our most successful way to market and have a fun event around dry eye and aesthetics. Because, and I have patients that are like, are you doing that thing in December again? Make sure I'm on the mailing list. This is like in May. And they will line up like 80 people deep coming into the practice. It is crazy, but it's wildly successful. So utilize things like that, like in your practice, and have a fun. It's basically like a trunk show on steroids. But it's a cool way to incorporate some fun things in your things you're doing in your office. Okay, so I love this title, Eye Candy. Elevating beauty and function with ocular aesthetics. And whenever I started down this path, right, I started in ocular surface disease. I was in a high volume LASIK cataract surgery practice during my externship back when we had no therapeutics and dry eye wasn't even a real disease. But I was exposed in that moment, and you'll talk to all the dry eye people, and there will be a moment in time when there's a story that they're like, I'm never going to let a patient ever go through this again. It's impactful. And for me, that was just so happened to be when I was doing my externship and I saw what ocular surface disease did to patients' psyche and the repercussions of what was happening with their vision. And so I was always very close with dry eye. And then I just started to notice that people were doing things that were complicating their dry eye. And then I was like, okay, how do I help them do that? And then they started asking more questions. And they're like, well, do you have anything that can help me? Actually, yes, we do. And while we're helping your dry eye disease, I can also help your skin look better. So this thread that we have pulled just continues, and I still learn and are still adding things. So that's kind of my background. And, you know, and Corey's in the same way. When you start to pull that dry eye thread, aesthetics is just a natural part of that, right? All right, so there's
mine.
Woo!
So you got mine now.
Mine haven't changed. I didn't sign up with anybody in the last couple of minutes, so we're good. It really is more than just vision. And how many people in here have an optical, you're doing frames in your practice? How many people in here fit contact lenses? You think a patient puts a piece of plastic in their eye because they want to? They do it because they want to see and because they want to look different. They choose a certain frame because they want to put whatever that is out into the world in their aesthetic. You're already in aesthetics. It's just a reframe of what you're already doing and taking that to the next level and thinking about it differently. That's really my goal, is to make things and people think differently about what optometry is and can be. And vision is considered the most precious sense. When you ask someone what their biggest fear is, that I'm going to lose their vision, right? They're like, I will lose my hearing, I'll lose all kinds of things, but not vision. And they do so much more. And the eyes are unique. That's the first thing that people see when they look at your face, which always blows me away when you get a frame that's crooked and well, I'm like, what are you doing? But it's the fastest thing that ages in the body too, because the skin there is different. It's 0.5 millimeter thinner. The skin barrier function is different. And certainly, you know, considered the most attractive part of the face for both men and women. That's where your social cues come from. This glabella complex is where you get all of your emotions. You know, you frowny face at your kids, you raise those eyebrows, all of those things, you know, teach what's happening with the body, and it builds confidence. There's quality of life. It's so many things that we can have a major role in.
Yeah, it's one of those things too, where so many of my patients, so the other thing from this, and we have artificially separated beauty and health, and they're tied together so often that we forget that classic markers of beauty are also markers of health. So really, that's what you're looking at with this. And so many of my patients, almost sheepishly, when they come in, and they're coming in for dry eye, not even like cosmetic things, they look at me and they're like, well, you know, the redness, sorry, they're like, sorry, I'm vain. And I'm like, you're not vain. everyone wants to look their best, and that's male or female. That's the other thing. We think so often. We're starting to see that shift where men have always kind of been like, oh, no, I don't care. And it's not that men don't care. It's that it's never been acceptable to say they actually care about this. So I always immediately like stop the patient right there. I'm like, no, don't worry about that. There's no shame in wanting to like look your best and function your best. And I can see they kind of light from that. I'm like, it's my job to get your eyes looking as good as they can and functioning as good as they can. So really, it's a false dichotomy that, like we said, we're already in aesthetics, whether we know it or not. So really just keeping that mindset that you're going to be helping the patient both ways.
There was a really cool study that looked at Purkinje images in a dry eye patient versus a normal patient. And, attractiveness is a twinkle in their eye and like that sparkle. You're not going to have a very good sparkle if your tear film is terrible, because that Purkinje image and that reflection is not there. So to your point, like we've separated this artificially but we can't. And so we've blurred those lines between beauty and health. And I want to just keep on smudging and making it blurry. So let's, I like to remind people that eyelashes are there for a function. They are not just an adornment. That is not part of your face that just exists for no reason for you to do things to, like put lashes on that enter the room before you do. They're very much there to protect the ocular surface and keep things off of the cornea. When you make the lashes too long, it doesn't do that. It creates a vector, and now it invites things onto the front surface because they're a width and a length for a reason. It should be 1/3 the width of your palpebral fissure. And that's important to remember. And my biggest, and I can't believe it took me this long to realize it. I was like, I have all these like dudes with the long eyelashes. I mean, my dad was one of those that had to cut his eyelashes because they'd rub in his sunglasses. It drove him nuts. And I had all these patients, and I'm like, why is it that the dudes get long lashes? And finally, the light bulb went off, and I was like, it's not the dudes. It's the fact that we put junk on our eyelashes that make them short and crumbly and fall off.
Yeah, it's funny you mentioned that, because my mom always said I would have been a really pretty girl because I have really long lashes, and I'm sure that had no repercussions on me whatsoever. But yeah, I also joke, do you know where I've seen the most lush lashes? VA clinics with all the old men who are on prostaglandins, which we'll talk about. So that's where I see the most luscious lashes. But I love when you all say it's not for adornment. And the other thing about this is I'm always astounded by the engineering behind the ocular surface. When you say there's that specified length, it's the weight, but the other thing is also air current dynamics are actually affected by that length. If they're too short, it's just blunted and things are just going to fall in the eye. If they're too long, it's actually going to redirect that air current. So it's just, again, to me, I geek out about the fact that this is just so finely tuned.
And think about it. Are our patients going to know any of that?
No.
Right? And so we're doing them a disjustice by not talking about this, but it can be uncomfortable to talk about. So we're going to give you some pearls on how to talk. So looking at all the things that can happen to the ocular surface, we can have dry eye. We can, certainly sabotage your best efforts to treat their dry eye. We can cause dry eye, meibomian gland dysfunction, blepharitis, rosacea, eyelid disorders, lash changes. All of those things are ocular surface issues and eyelid problems that are medically based, but certainly affect how our patients look and see their very best, right? Cosmetic concerns, we talked about looking at lids, and the most important thing I can teach you is how to look at a face. And when you think about periorbital, what does that really entail? And if you would ask, depending on the board that you're talking to, maybe that's 2 millimeters away from the lash line is considered periorbital. It's not. When you assess a face, periorbital starts at the corner of your mouth and it goes all the way to the forehead, because all of those muscles and all of that work together around the eyes to make sure everything is supported. So we have to understand the anatomy to know what the problem is, so that then we can work on how to address. But, patients will come in with hey, my eyes are saggy, they're droopy, my eyelids fallen, I got these dark circles. I have a whole lecture just on dark circles alone. Lashes misdirected in appearance, redness, glassy, tired. But I have if you have a patient that walks in that looks like this, what's your first question going to be? If they're not a glaucoma patient. That was a hint. What kind of lash serum are you putting on, right? You can see these kinds of changes because you see it all the time. When you have somebody that's got, in ophthalmos, they've destroyed all their fat because they've been on a prostaglandin for decades. because they wanted long lashes, and there's unintended consequences with those decisions that they unknowingly made based on information that they don't have. This is one of my favorite studies looking at dark circles. So if you want to take a deep dive into this, pull this paper. It's one of my favorites because it walks you through why the dark circle is there and then looking at how to address it. This is the hardest question, and I always cringe when patients ask, they're like, "Can you help me with this dark circle?" And I'm like, I can, but let's have it.
Yeah.
It's a longer
It's tough.
conversation.
I will say, when you get into these aesthetics thing, there are like almost like three horsemen of the apocalypse I often think about, and dark circles is one. Erythema is one.
Yep.
We've gotten better, but redness is a tough one.
Yep.
And then the yellowing of the conch and this flare, like those three, because those are the biggest cosmetic complaints we get.
Yep.
And they're tough.
They're tough.
They're tough.
But that's important to know, because the patient's spending, $400 on a face cream that's not going to do anything for a herniated fat pad, right? So those are educational things that you can now talk about. And then you've got, like we've talked about, functional concerns, whether it's their vision and tear film instability and ocular surface and inflammation. So when we look at these conversations, it's important to get comfortable with them, and you can have just some simple questions to ask. Tell me more about do you put anything specific on your lashes that's making them grow that you want to like have a serum? How do you take your makeup off at night? Do you sleep in your makeup? Those are like just some really simple things.
Yeah, and I think it gives you a good gauge of things. And I know we'll talk a bit more about cosmetics and makeup specifically, but I honestly say, if you want to have a bunch of dry doctors get into fist fights, have them talk about cosmetics. Because it is the most contentious area of debate and everything. And so for me, I'm learning because I don't have much hands-on experience with makeup. So I defer to those who do. But it's one of those areas, but I've always simply asked exactly, what type of makeup do you wear? Are you taking it off? So you don't have to be an expert on every single ingredient to ask some of these basic questions.
And no one's an expert. There's so many ingredients, it's physically impossible. So you just have to give people tools and ask the right questions to get to that. But I think the big tipping point for me when I really started to put these kinds of lectures together is one of my top colleagues in Oklahoma. He was the first OD to ever do PRK. He's brilliant, and he's a great cornea person, and he does some dry eye, but he had a dry eye specialist, and he's like, we do this, and I just tell patients not to wear makeup. And I was like, really? That was your answer? I was like, you tell them not to wear makeup? And I was like, do you ever see the patient back again? And he's like, that's a good question. I don't know. And I was like, yeah, I promise you they're not. And that's not a solution. And I love you, but that's not a solution.
No, and it's the equivalent of out here, where you've probably heard this a lot for our dry patients out here in Phoenix, where they're like, oh, you have dry, you just need to move. Like it's the same concept completely. And it should, and yeah, I get that so many times. And I'm like, oh yeah, kids don't need to go to the same school. They don't need friends or social stability. You can just get a new job. You can just pick up and move. So, but more or less, it's like an extreme example, but it's that same idea where you're like, let's just avoid it entirely. Like, let's avoid just the practicalities of life. Yeah. And again, I always recommend taking a very pragmatic approach. So it's like, yeah, if you're going to wear makeup, let's just figure out the best way to do it.
Yes, in a responsible manner.
Yeah.
And this I love, because how many people in here do wide field photography in your practice? Lots of you, right? Yeah. What are we looking at when we look at these images and we go through them with patients? What do you talk about? Retina, optic nerve, blood vessels, everything looks good. What else do you see? Eyelids in the way. There's an opportunity. Look, I can't even see all of your structures because your eyelids are blocking what I need to see, which means they're blocking you seeing out, which means we're limited by light, which means that you don't have the kind of vision that you could have if this was addressed. Same thing with meibography. We were there to look at meibography, but whoa, what's happening on that upper lid? There's so much dermatochlasis, you can't even see the lashes. So we're doing things already in our clinics that just invites us to, like you said, look, but really see what's happening.
Yeah. And we've all had that when it gets really bad and you can't even see the optic nerve. And when I tell the patients, I'm like, it's lost in the bushes. Like I said, I'm like saying this, it's all down there in the bushes. I can't even see it. And so, yeah, it's little things like that. And they kind of get the idea. I mean, I like to use humor in an exam because, every single day we do things that can be very serious, but I like to try to keep it light with patients and they kind of get it. But the thing is, you bring them to this awareness to a problem, but in a way that they're like, okay, yeah, I can see it, instead of being like, oh, I have this problem, and they get all tense about it. But yeah, I love that. There's so many different treatments. I mean, like different diagnostic things that show us beyond what we're looking at. Yeah, we're looking at the retina, but you can tell so many things. Or again, your tech. When you see two techs at your wide field imaging at the OpCos and they're both holding it up, you know, you already know. You're like, oh, okay, we're going to be having that conversation.
And patients don't know that there's solutions to this. So whether it's, using, if they've got blepharoptosis, then we can utilize oxymetazoline. If they have, maybe they need, even more surgical. But if they have dermatochalasis, what they don't know is the fact that many times it's different between functional and cosmetic. They have no idea that they can have a functional blepharoplasty that their insurance covers. They have no idea.
And I'm
that
assuming, do you do fields in your office?
Yes.
Yeah, I do too. It's one of the biggest things. Even if I'm going to send them oculoplastics, I like to do the field because I can show the patient there. I'm like, here's your lids taped versus untaped, and they get it. So I personally really like to always do those in the office.
Yeah, I love the question. I'm like, do your eyelids bother you? And they're like, what do you mean? And I'm like, well, you're sitting here looking at me with your head like this.
Yeah.
And I make them like push their head down. And I'm like, this is why you do that, because you're looking out underneath those eyelids. It's like, oh, this is uncomfortable. Or, they're utilizing that frontalis muscle, which is the only elevator in the forehead, to pull all that up out of their way. Exhausting by the end of the day. I mean, if you sat here, this is not too uncomfortable, but ask me in 15 minutes if my shoulder's starting to be on fire. It's the same thing by the end of the day. And a lot of times our patients will have trouble driving at night.
Yeah.
What's our highest differential for that? Oh, they have cataracts.
Yeah.
Well, it might be maybe they do, but they also probably have a lid issue that by the end of the day, their lids are so droopy that they're limiting how much light's coming in.
That's a big one. I always say, I'm like, aren't the drivers here in Phoenix really bad? They're like, yeah. I'm like, do they just come out of nowhere off to the side? They're like, yeah. And it's like, I'm like, well, part of that actually, because the lids are down from that. And they're like, oh yeah, because they're always coming out of nowhere.
Yep.
And
I love that.
Yeah,
I'm totally stealing that.
Oh yeah, because they're all like, oh yeah, they're so bad. They come out of nowhere. But that's honestly one of the first things they don't realize is they're getting that restricted field. So again, what does that come down to then? We're talking about cosmetics and aesthetics here, but that's that functional thing. This is a huge impact on not just, their visual field, how they can function, but like you said, just that strain from just carrying that weight all day.
Yeah. This is one of my favorites. So I went back to, and this is the same patient viewed in multiple different ways. So this top one, this is how I used to see patients behind the slit lamp. Can't really see a whole lot. I can tell they've got some telangiectatic vessels, but I can't really see the base of the lash. That's on 10x, 16x, 25x. So I like 16 the best because I can really see all the collarettes, the telangiectatic vessels, but I don't miss the forest for the trees. 25 I use to like really dive in, but 16 is kind of my normal setting.
Yeah, I agree. And that's kind of one of the big things I would say is too, you change mags. That's the big thing. I like to go on 10. I'm a big fan of, like, you can't stay static. There's things you miss. I like to take in the overall gestalt of everything on 10. And then once I see things, 16 is really, really good for that.
Yeah. And then this picture on the right, I put in here because a lot of us talk about eyelash extensions, but not all of us fully understand what that is or what people are doing or the why. So I have this in here. So remember that an eyelash extension is a fake lash that's anatomically glued to a normal lash. And there's multiples of these, which is why it takes anywhere from 2 to 4 hours to put these on. And the patient sits through all of that, but they're glued on. And so when you're looking at this, the difference between a collarette and glue can sometimes be a little tricky. But your collarettes are going to come out of the hair follicle down here, and it's going to like sleeve up around and you guys already heard my conversation of why that's happening. And then your glue is going to be closer to the lash, but sometimes it's horizontal, sometimes it's a ball. And like, like this picture, there's actually one that like broke off and you're just seeing the glue that's like still there.
Yeah, the glue is going to migrate. That's the easiest way. You can occasionally get that with collarettes, but it's much rarer.
Yeah.
So that's what it is. If you see it migrating up the lash, it's just following the growth pattern of the lash. Whereas those collarettes will continually stay at the base. So if you're unsure, now if they put them on fresh, it's going to be a little bit harder.
Yeah.
But that's the easiest way to kind of differentiate them.
And you bring up a point, remember, because how long do our typical lashes last? Around 4 to 11 months. So there's this normal growth pattern. So what do these patients have to go do? They have to take off the lash, they have to dissolve all the glue, and they have to put them back on. And that happens about every 2 to 4 to 6 weeks. The patient is going through this. The glue solvents are typically highly toxic to the ocular surface. And the glue itself is sometimes because it often contains formaldehyde and latex. So that whole process, when I walk patients through that, is helpful, but I find it helpful for those of us that don't fully understand eyelash extensions. Yes. No. So his question is, do most people take these off every night? They don't because they're glued on. So here's my thing on lashes. This is besides lash tint and curl, which is a perm solution, that's always a hard no. If patients ask me that, like, can I get my lashes tinted? And no, absolutely not. If they do this, we have a conversation. And if they say, okay, well, I'd really like to leave them on, then we talk about how to clean them. And then if they say, okay, well, can I do something? If you do glued strips, that's better than this because those you do take off every night. But these, they stay on. All right. Lashes. The other question that I always ask is, what are you putting on them to make them grow? Do you put anything on? Because the difference between a synthetic prostaglandin and a prostaglandin that we prescribe, these have to go through the FDA process. Synthetic prostaglandins do not. There are hundreds of products over the counter that have prostaglandins in them. And I'll share this story. I had a patient that was she was a self-referred dry eye patient. And she drove 2.5 hours, found me on the internet, and she's like, I have been to doctor after doctor after doctor, and no one can help me. I'm miserable. Before I even got into the exam, I'm just sitting and talking to her, and I said, what are you putting on your eyelashes? And she named off the thing, and she goes, is that a problem? And I said, that's a problem because it has this in it. It's we know it has meibomian gland dysfunction and dry eye problems. This is certainly, and she's a type 1 diabetic, so she already had a lot of risk factors. So it wasn't, but the point to the story is she said, but you guys prescribe it all the time. I did my homework. This is something that eye doctors prescribe every day for glaucoma. It's safe. That was her perception because we prescribe it for glaucoma, that it's safe for her to use on her eyelashes. But she didn't know all of the things that go along with a prostaglandin on the ocular surface. And that I was the first person in all of those doctors to ask her that. And I think I was 5th or 6th in that. And she's like, I cannot believe for 10 years I have been going through this, and that was my perception. And she was well educated. So they just don't know what they don't know.
Yeah, I'll say sometimes, just enough to be wrong is the problem, because you lure yourself into this false sense of security, because what she didn't realize is when we put a patient on a prostaglandin, we have that conversation. We tell them, and at that point, it's like, why are we using it? Because what's the alternative? Vision-threatening disease.
Right.
So, okay, yeah, you might have to trade off for some of the cosmetic concerns because at the end of the day, we need you to see. But again, it does lure them into a false sense of security. And that's why I agree. It's just ask these questions, especially because many things are unregulated.
Yes.
You're going to go there, they're going to get something over the counter.
Yep.
And they won't even know that it has a prostaglandin in them.
And it's buried in the ingredients. Like I don't think I have that in here. If you look at the ingredient list for any of these, like online, the active ingredient will say hyaluronic acid and aloe vera. Really? And then about 25th ingredient down, it says isopropyl cloprostinate. And there it is. So even the way that it's labeled doesn't have to be, it's not regulated. I had a 13-year-old that came in and I was like, those lashes look real suspicious. And I asked her and she's like, oh yeah, I got this thing from my friend. And I looked at her mom and I was like, what'd she get? And she goes, I have no idea what you're talking about. She goes, what did you get from your friend? And it had a prostaglandin. She was 13.
Yeah, and that's another
really scary
thing. Unfortunately, going back to the whole pediatric thing is, I think it's important that we pay attention to demographic trends. And one of those now is we're actually seeing cosmetic use younger and younger. Like, I mean, again, I'm a guy, so I this is like research purposes when I read about cosmetics and everything. And I hear about like Sephora, like hordes of like 12-year-old girls like going in there and just like ransacking the place.
it.
But when I start thinking about that, like everyone's like, oh, sociologically, all those factors. But to me, I'm like, these poor girls, what are they doing to their ocular surface? Yeah. Because here's the other thing. I remember when I first got my contact lenses, I was 12. Boy, did I sleep in them. Boy, did I do everything wrong because I was a dumb 12-year-old. So, even when you're an adult, you're trying to be good and take off your makeup. Do you think these 13-year-old girls are taking off the cosmetics? No. So what's going to happen when they're in their 20s? So we really have to pay attention to these trends.
We're the subject matter experts, not the TikTok star, not the Instagram star, whatever trend is happening. I have an 11 and 14-year-old, both girls, and I have trained them well. They're like, can I use this, Mom? Can you look at the label? Like, I'm winning. Oh, I do have it in here. So this is, and I normally don't put but key ingredient, hyaluronic acid, aloe vera. This you actually have to click to see the rest of this, but there it is. Isopropyl
And
glyphosate.
patients will never click that. And
Nope.
here's the other thing. They look at the active ingredient in Latisse because that's what they compare it for. And then they're like, no. So if they don't see it, they're like, nope, there's no prostaglandin because they have no clue that there's more than one.
Yep. And the other thing people often ask, like, well, do you prescribe Latisse? I still will prescribe Latisse, but I have a consent form and I bring the patient back every 3 months to look at ocular surface and make sure there's no issues.
And how do you tell them to use it? Because this is a big thing too.
So only at the base of the lash with the little brush. Not more is better, because I've had patients, they're smearing it all over the lid and like it goes from here to here on the patient, right? It's everywhere. I'm like, no.
And I tell them to pat any excess off.
Yes.
I'm very big about that because you don't want it on the skin or anything like there. Because I tell them about this. I'm like, you make sure, like you said, I'm like, this is supposed to go one place only. I want you to even dab. Because here's the thing, even if it's less effective because they dab some away, I don't care.
Right. I don't want it on the skin. Conjunctiva. Oh man. These eye whitening procedures where they're doing, you want to talk about that?
Yes. So first of all, remember your question about ocular rosacea earlier? These vessels, this is a great classic appearance to these because they're going to be hyper spidery and very thin, and they're going to perpetually like stay dilated. So this is a good example of very, very severe, basically ocular rosacea. But to the eye whitening procedures, have you seen one of these before?
I have.
So there's not many people who do this. There's one ophthalmologist I know, I believe he's in New York, and he's been sued multiple times, but he's like entrenched and he keeps doing this. Have you guys ever heard of this procedure before? So do you know what they do? They actually strip the conjunctiva and the vessels away. So that's how they remove the redness. And when you look at the site, it's terrifying how it describes it. And he makes it sound so nonchalant, like, oh yeah, you don't need this. I'm very much like, the anatomy is there for a reason. And the other thing too is I'm just thinking from the immune perspective, like how like also susceptible you are to like infections, things like that. So also the goblet cell loss, just all of this here. But they go in and they just, and then they also use mitomycin. So they make sure they just don't like kill it. It's like napalm. It's gone. They are salting the earth behind it. And I had a patient for this. And I'll tell you, I remember this is like when I first started. It was also funny because I'm like, I'm in the right place. When I first saw it, it's like my first year here. I'm like, this is the type of stuff I want to see. This poor guy had it done. And he had dry eye before. And he came back and it was the worst ocular surface disease I'd ever seen. His eyes, like you could see, like, you know how you should have that sheen from like basically just like kind of the fluid dynamics on that? It was matte. Like that was the thing, like his color was like matte. It was just so dry. There was no light reflex on it. And the thing is too, this was white, but everywhere around was bright red. The lids were red just because, again, he had so much inflammation because he had basically done this. So, I mean, it's butchery. I'm going to call it what it is. So if a patient ever asks about that, especially the ones, and you get a sense for your patients when they really are getting desperate, let them know that this is not an option.
And they're often using, drops over the counter that we don't want them on. So that's another important conversation to have. And, looking at this question comes up a lot about retinol, and that is the one topical that has good data behind it that it does work, but there's some caveats to it because we know that if it migrates into the meibomian glands, it destroys them. So if I have a dry eye patient, I don't let them use retinol. If I have a non-dry eye patient, they want to use it, they still say stay 2 finger widths away from anywhere around the eye because I don't want it migrating into the meibomian glands, and they have to wear sunscreen because you make them more susceptible to skin cancer, because what retinol does is it turns the skin over faster. But it does work. You have to slowly get somebody into it, but you have to wear sunscreen.
I love what you said for the 2 fingers because it's easy for a patient to understand.
Yes.
And I feel my patients out for this because some are going to do it no matter what I say. So that's exactly where I try to make it safer, not safe, but that's why I'm saying like this is a safer way to do this. This doesn't mean we're going to avoid all complications, but it's safer.
I got to be part of the TFOS lifestyle workshop on the cosmetic subcommittees. And so we took all of this information that we had that we could find in the literature and put it in a paper that was published last May. So that's a nice resource that you can take a deeper dive into on the impacts of ocular surface. This is mine that I developed because whenever I gave this course, it was so frustrating for you guys and for me because at the end of it, they're like, great, Selena, this was awesome. I know what not to do. Can you please give me something I can do? So here you go. So use this, not that. And these are all what I can at least find in the literature that has benefits, but the prostaglandin analogs, avoid. And you can definitely use polypeptide and lipopeptide lash conditioners. And there's several over-the-counter ones that are just polypeptides.
We're getting more and more of those too.
Yes.
By the way, this is an area your patients will ask you about.
Yes.
So this is the great thing is that this is starting to, even though again, I get secondhand TikTok information from my techs, so I don't dare go in there. But they said that they are thankfully starting to see some like influencers who are like talking about health and healthier alternatives to this, which is good. So your patients will ask, so be prepared for that.
Yeah, and these are easily accessible over the counter. If you have someone that you can talk into removing their lash extensions, which I've had some good success in the last couple of years, the trend is starting to move this way. And they're like, well, gosh, when I take them off, I know my lashes are going to be wrecked. And they are. But if they do a polypeptide conditioner, that will also help their lashes grow out faster.
I love what you said before, too, is that beauty trends change all the time. So that's what we're going to see. So right now, the lash extensions can be very in, but things change all the time. So that's a good thing to keep in mind for this. And the other thing I like that you have here is the makeup removers. So again, when I say I'm pragmatic about makeup, one thing I think, and again, this is my opinion. I will not say I'm the expert for this, but what I've seen clinically is I feel like outside of some really egregious ingredients that we know are very harmful,
right.
I feel a lot of makeup related dry eye isn't necessarily due to the makeup itself because we have a very good protective barrier with the skin. It's the lack of fully cleaning it off.
Correct.
So it's that chronic exposure. So I'm very much with my patients who still want to wear them. Like, okay, you can wear your makeup. These are safer alternatives, but you have to make sure you really clean it off.
And you have to be careful about how you clean it off because remember that I talked about the skin, there's 0.5 millimeter thinner. So it also has to do with once you break down the skin barrier and that component, anything that you do is just going to strip it that much further. So it really matters how they take it off. And I like micellar water, ionized water, both of those things. And both of those are available in like eye care formulations that you guys can either carry in the office or you can have patients be able to get. I asterisk this because sometimes they'll trick you and put some things in micellar water that shouldn't be there. But those are my two favorites. Don't use anything that's oil-based because you can't get that off. The reason that you don't want to use waterproof mascara is because you have to use something oil-based to get it off, except for you can actually use micellar water and ionized water. Both of those, if you leave them on there just a little bit longer, it will actually take off waterproof mascara. Eyeliner on the water line, or they call it tight lining. Eyeliner right on top of every meibomian gland orifice, right? And that is bad. And they don't know that. They don't know that there's 30 little glands there that are making oil for the front surface. How would they know that? But so we have to have these conversations of put it on the dry side.
And that reminds me too. So what are your thoughts of tattooed eyeliner?
Oh, no. So blepharopigmentation, that little tattoo needle punches through every single meibomian gland. My patients, my worst dry eye patients that we have done everything with, the most miserable patients are the ones that got blepharopigmentation. And they will redo that because it only lasts about 3 to 5 years. So unfortunately, patients will do it. And by the time I see them, so I just educate, listen, you can't ever do this again. I've had 1 or 2 patients that said, I wanted to do this. And I was like, oh, thank gosh, no. And I tell them why, but no.
And the thing about that is because that's actually something I document when I do my dry eye assessment because it can have such a big impact. But here's the thing. This is, again, just a kind of a lot of misguided thing for a lot of the patients. They're like, I'm going to be healthy. I'm not going to use makeup. I'm just going to get it tattooed. And it's because they don't understand the anatomy. So a lot of them actually have good intentions with it.
Absolutely.
They're like, yeah, because my eyes will get irritated from makeup. So it's kind of like our patients who have like contact lens intolerance. So they get LASIK because they think it's going to fix the problem. So it's a good analogy. It's an educational thing for them again. And sometimes it's the best of intentions.
They just don't know.
Yeah.
I mean, and it's so unfortunate. And that's why I love talking about this because we have a front row seat to being able to guide patients through this, and they're desperate for this kind of information. It doesn't exist. So if you have these conversations, you'll be pleasantly surprised how grateful your patients are for it. Accutane is a big one, and I don't think it's in this slide deck. I had a 17-year-old who came in recently for an eye exam, and she's like, my vision's just really blurry, and I am on the struggle bus, and I've been on the struggle bus for about 3 months. And I was like, okay, let me look. And her corneas, goodness, lit up like a Christmas tree. And she'd been on Accutane for almost 10 months at that point. Her best corrected vision was 20/40. Kids driving around. I mean, she's 17 driving. And we walked through all of this, and her mom was like, what? And so she had destroyed most of her meibomian glands. She had about 5 left. No one knows that. Dermatology doesn't know that. And this gets prescribed all the time.
Yeah, ask. Every single one of my dry eye patients, I either ask them a history of use, because I've intercepted a few, and kind of like you said, good thing you've talked to me first.
There she is.
Oh yeah, this is
her.
And this meibography, you can see, I've seen that again. It just wipes them out. But if you can intercept a patient, and it's exactly what that is. Oh yeah, my dermatologist just did this. So this kind of goes back to the aesthetic thing. And here's the other thing: when you look at your patient, look at their full face.
Full face.
If they have acne, I ask them immediately about it, because the chances that if it's like visible acne, the chances of them eventually seeking care and getting prescribed the Accutane is high.
Yes. And I've had a couple of wins where I caught the patient before they started it. I was like, okay, well, we're going to start it, but you're going to come in once a month so we can assess ocular surface and look at meibography so that we see a problem, or we can get ahead of it. And so I'll do serial testing through that whole round of Accutane. But if she had gone to someone that wasn't as focused, and we missed the fact that she was on Accutane, if we didn't do vital dye, if we didn't do meibography, this kid would have walked out with a pair of -1 glasses and been like, maybe it's a little better. So there's just a lot of opportunity here. Merging beauty and function, we can do lots of things. Corey's going to take a deep dive into IPL. And this is like one of the easiest ways to blur those lines, because you're treating dry eye disease in a simple tool, but you've got all of these other settings that you can dive deeper into, literally the skin and what's happening there on a different level. And radio frequencies like that too. I mean, I do laser resurfacing. I do neurotoxin, not on a dry eye patient, because when you paralyze the orbicularis oculi, you change the blink reflex, and you either cause dry eye or you make it worse. Maybe you're not doing neurotoxin injections, but I guarantee you in Phoenix, Arizona, your patients are having it done.
Scottsdale, you know what I'm talking about. I just had to say Scottsdale. You guys all know exactly what I'm talking about right there. And to Selena's point for this, thankfully around here, I find a lot of the derms, or like the doctors who do Botox, they are excellent at listening to the patient if you give them a letter or you have them talk to it. Because again, patients out here sometimes are going to do it regardless of what I say. So I'm like, listen, if you are going to get, I'm like, I want you to be bluntly honest with me. I'm like, this is not a place for you to feel like, you need to lie or anything. Like, tell me, are you going to do this still? If you are, what I want you to do is talk to whoever's doing your injections. I'll even can write a letter for you if you want. Let them know that you have this condition. So I want them to be more conservative. I want them to avoid these areas. And you know what? Most patients are fine with that. They're like, yeah, because they want to do it, but they do want to be safe. So I just always have that conversation. And I have found that those who are doing it are very amenable to that.
That's how I even started doing neurotoxin, because I just had so many patients that they were just overly injected and they were having a lot of issues. And I was like, you know what? We're not doing this anymore. Yeah. I'm just going to learn how to do this myself, and then I can manage it from that side. This is a classic rosacea patient. That chronic blush, rough skin, miserable. She hadn't worn makeup in 2 years. Quality of life greatly diminished. Just very self-conscious, thought about her eyes all the time. And this was after just 2 settings. But this is a perfect example of, if I only did the dry eye settings with IPL, I missed the rest of her face and the rest of the disease process. And so when you have IPL, and he's going to go into this, there's lots you can do there. So I'm pretty aggressive when it comes to that. Radiofrequency tightens skin, so you can tighten blink reflex. You increase oxygen because you're improving blood flow. Lots of different ways. These work beautifully in conjunction with each other. So one tightens, one is for skin texture and redness. And so the nice thing with all of these energies is you blend them together to get the end result that you really want. This is one of my patients that was in the optical. And she was a newly presbyopic. That's an insult already, right? She's already like mentally not ready to accept anything. She's in my optical and she's like, I hate the way my face looks. I don't care what glasses I put on my face. I hate it. I was like, great, I can help you with that. My heart's broken for you and we're going to fix that. She's like still one of my best patients. Like about every 6 months, I get a text message from her. She's like, I can still see my cheekbones. I'm so happy. I love you. So there's like multiple ways to put that in. Microblepharoid exfoliation. When you're improving, it never ceases to amaze me when patients come in with lashes or lash extensions, and then everything around it is like the color of, his shirt. I'm like, it's like, that's totally like seeing the trees and not the forest, because the lashes look good, but nothing around it looks good. And these kinds of treatments can really help.
Yeah. So, and the thing about these are great. And the other thing I often say, these are very easily accessible, because when we come up here and we talk about this and you look, you're like, I love IPL, I love RF, I do it all the time, but I know a lot of practice, they're like, well, we don't have the space for that. This isn't like something that for us we can do, though they're amazing technologies. Like I will say, if you want to start with basic things, microblepharoid exfoliation is the perfect entryway, because that's normally lower cost, quick to do. You can delegate it to your techs. So I say that type of procedure is a great first step if you want to kind of dip your toes into the dry eye and even the aesthetic world.
Yeah, absolutely. And like when now that we have water liner, I still do microblepharoid exfoliation.
Yep.
Because I want all of that off of there, because that's all pro-inflammatory. So the patient immediately feels better when I get all that junk off. And then I prescribe water liner, because it's going to take about a week to 10 days to get the medication. So then it's like a 2-punch, basically. We've talked about injections. So there's, lots of different neurotoxins that patients can utilize. And on the face, at least, and it does work really well in the space that we play, which is here to here, right? So that forehead muscle, that's the only elevator in the forehead. So you have to be careful there, because if they've got ptosis already, all you're going to do is make that worse. The glabella complex is easy to inject. It's one of those that, that's your frowny face, and there's the procerus here in the middle and the corrugators that you can soften. And then the orbicularis oculi for crow's feet. But again, you're going to be careful in those areas, but it's so important to know if the patient's going to do that. Because, and this is a classic example of those 11s that people talk about. Sometimes they'll just have a 1, sometimes they have 3 of those. I don't know what that would be called. But maybe like Roman numerals, I don't know. But these are treated with, because this is a dynamic wrinkle. So we get wrinkles because the muscle underneath it is forming that skin over the top because of the movement. So if you paralyze the muscle, then the skin can't move it and can't make that wrinkle. But I like to do things all together. So I like neurotoxin to soften, but I also like radiofrequency and IPL, because I'm building collagen with RF so that the muscle and everything around it still looks better. And there's just a lot of different ways that we can get to that. But, when you have patients and sometimes they'll do this in their sleep, and that make that frowny face. And so you can just relax that. But she's just moving that muscle, another classic example. And it just depends on how active that muscle is, of how much I do and how many injections I do. Every patient's a little bit different. That's the fun part of this, is there's so much art to this, which feeds my creative side of my brain, to help patients with this, because they're all a little bit different. But laser resurfacing, I started doing about 2 years ago, because my derm colleagues don't want anything to do around the eyes. Yeah. So I have lots of patients that have full face laser, have full face things done, and they're like, but my derm stops here and they don't go here. And there's opportunity in a niche for us, because I have no problem putting in a 26mm scleral metal shield, right? They don't want to mess with that.
No, and it's the exact same thing I'll tell you for radiofrequency. Like I've already had patients who do this, because it's super common. A lot of patients who I have had aesthetic procedures, and they tell me the same thing with radiofrequency. Oh, they do my full face, but they avoid the eyes, because if you look at all of their device manuals, it says avoid the eyes, which we now have research for this. But again, and you mentioned this before, the thing is, remember, we're the experts in this area. Dermatology isn't for this. They know the skin really well, but again, they're like the eyes, because they know like it's a sensitive organ and that's it. And they're not going to mess with it. So we are the ones who are best trained to kind of step in this area.
This is one of my favorite patients. So this is she came in for a comprehensive exam and everything was good. She's like, okay, great. Got my contacts. And she's like, these dark circles are killed. She's like, can you help with this? And we've had the dark circle conversation. I was like, I can help, but I don't ever like to make promises that I can't deliver on.
Yeah.
But hers is pretty classic. I mean, she's a skin type 1 to 2, And she's just got, venous pooling underneath because the skin there's gotten thinner. She's lost a lot of that she's lost a lot of that collagen in her face. And so with her, this was a perfect time to like rebuild. And so I did multiple things. I did IPL and a 1540, and there's different laser resurfacing. You can do a CO2 laser, which is ablative. You're literally intentionally delivering a second or third degree burn. Most people don't want that kind of downtime because it's a 2-week downtime and you might have some redness for up to 6 months. But with a non-ablative laser, you just have to do more treatments, but there's much less downtime. So it's 24-hour downtime, and then you can put sunscreen and
have you
stuff
seen,
on.
I feel like things are kind of trending that direction now.
Yes.
So where more people are willing to come back for multiple treatments if it's less damaging. It's like almost think of how we've changed like from like SLT, because it's more like we're doing kind of like little micro damage instead of these really kind of big damaging procedures, and patients respond to that. But the other thing I love about your picture is just look at the demeanor change.
I know.
Like that's the biggest thing. Yeah, like she looks better, but it's just the whole self-perception. Like you can see there's like more confidence there. She's just like happier, and that's why a lot of things when you're treating aesthetics, and this is with dry as well, we're treating the psychological component to our patients. So it's, again, we're not just making them look better for vain reasons, but that self-confidence, that self-perception is what we're addressing.
It's different, like it's joyful. And I share that because sometimes you can get in a mode of, this is optometry, I've done it for 10 or 15 or 20 years, and it just doesn't fuel my soul like it used to. And there's ways to practice optometry differently that can, whether it's especially lenses like Steph does, and people fly all over the country because no one else can help them. This is another way to help your patients in a manner that also feeds your soul as well. And so I love this. These procedures, when I do them, it takes about 20 to 25 minutes. And so we just have a nice little chat, and I get to know people, and I'm not rushed, 7 minutes to talk about my conversation. I jokingly like did the Lottolander discussion of what an ectoparasite is, and that was in 15 seconds. But I have to practice that all day, every day to get to that level. It's just different.
Yeah, like when I'm doing an RF treatment, that thing's on a timer. So I'm like, I've got this time. So I'm like, and the thing is, it's nice to be able to like, let's just chat because I'm I'm not up against the clock. I know I'm going to be here for this time. So I'm like, yeah, it's nice. And it's actually funny. My biggest problem I have with radiofrequency right now is patients start to fall asleep.
Yeah.
Because it's like very
so relaxing.
Because it feels
it's
almost
like a hot stone massage.
That's exactly what I say. And I've actually had patients start nodding. Like I feel their head like go, and then I'm like, okay, time to start a conversation again. Let's get talking again here because they're dozing on me.
Yeah.
So but it's, again, like you said, it's a nice kind of change of pace. And I mean, personally, I enjoy like variety in the day. So I like being able to like switch it up and go do a procedure. I like being hands-on. I don't like to sit and just do one thing.
I have ADHD. And so for me to like do the same thing, I'm miserable. And so about every 5 to 7 years, there's a new pillar in the practice.